within the UK NHS. And as a result, we have access to a lot of technology which has helped us during the pandemic. We've also had access to various other innovations, such as these hoods here, which were very useful at keeping people safe during very high-risk areas, and also things like digital whiteboards and iPads for entering observations. And because we have a strong collaboration with the university, with James Batchelor's unit at CIRU, we were in a good position to be able to respond during the crisis. The hospital realised that it was going to be very serious as soon as we started getting cases in Lombardy, and we were having discussions with doctors over there back in sort of early February and March. And as a result, we quickly started planning logistically how we would change operations within the hospital and how we might try to provide enough ventilator capacity for COVID patients while also supporting research and other clinical activity. Hang and I have put together some timelines of some of the events which happened, but the informatics response really started at the end of March. So on the 20th of March, the number of cases in the hospital really started to increase. And it was the 25th of March before Hang, James, Farina and a couple of other people started basically forming a COVID digital response group. And within a number of days, we managed to establish a reliable data pipeline, which we were able to use to power ventilator capacity demand modelling, regional modelling with Public Health England, and build dashboards for the hospital, and then subsequently to track infection around the hospital and do things like digital staff testing, as well as supporting research activities. And I'm going to go through a few of those things now. So the first thing we had to do was work out how many ventilators we might need. As you know, a lot of the work coming out of places like Imperial and Niall Ferguson's group cast very dire predictions of how many we might need and when we might need them. We were at an advantage in Southampton over the rest of the region in that we had real data, a live data feed, and Hang and I basically tried to build that and use that to project where we might end up and how many beds and ventilators we might need at particular points along the pandemic. This was extremely helpful in planning for the hospital's directors. And as time went on, we worked with other groups to try and help improve the quality of the capacity demand modelling, and I'll talk about that again in a bit. As part of this, I also mentioned that we developed several dashboards. So this blue graph here is looking at the number of triages, so 111 triages in the community. And you can see they acted as a leading indicator of the number of admissions coming into the hospital. And as the number of calls dropped off, we also saw the number of people coming in dropping down substantially. The NHS had added a flag to the calls so that they knew when people had COVID type symptoms. We also tracked the processing time in the lab and the number of tests being done. And we were able to track mortality and track various different cohorts and how they were doing as things evolved. That meant that we basically received the attention of Public Health England, who are responsible for looking after the public. And because we had live data, we were able to be the first to upload this into their system and helped other sites to do the same by basically using code and extracting from the back of the hospital system, the EPR. We also worked with NHS Digital, who are a national body responsible for trying to help improve digital work within the NHS. They, along with Cambridge University, built a tool which could predict ventilator demand. And we were one of the first alpha pilots involved in effectively contributing data to that. And we're still a key partner to that program to predict ventilator demand within the NHS. And that's very, very handy, because if there is a second wave, it will give us a much better idea about where we're heading going forward. And these are some of the dashboards that are available on that tool. The next thing was hospital-acquired infection. We realised very early on that a lot of the patients were catching the COVID as inpatients, i.e. they'd been in hospital for more than 7 days before they became positive. And we developed a nomenclature to describe that. So 1 to 2 days was not hospital acquired. 3 to 7 days is possible hospital acquired. 8 to 14 days is probable hospital acquired, and 14 days plus is definite. And we were able to track the outcomes of these patients and try and track the clusters and stamp them out as soon as possible. We also, we've developed a bot service within the hospital called MedXNote, and we were able to hook this to the results server so that we knew immediately as soon as a new patient flagged on a cold ward, on a ward that wasn't supposed to have COVID in it. And as a result, we were able to try and control these infections very quickly within the hospital. And as a result, we haven't had a single case of COVID now for 37 days, hospital-acquired COVID. So, so this has worked very well. Then the next question was about staff testing. So we basically organised our EPR such that all the staff developed a patient identifier, and then basically built a program of staff testing which would enable every single member of staff to be tested every week. And that's still ongoing. A whole process of consent has been developed around that, and we've seen steadily rising levels of testing, meaning that we can give much greater reassurance to our patients that the staff do not carry COVID, because one of the biggest contributors towards hospital infection is undoubtedly asymptomatic staff who have it. And this is something, another area where as a city and as a hospital, we're leading nationally. And then there's the also research side of this. So Hang, Farina and I have been involved in many different research projects looking at acute kidney injury, hyperinflammation, mortality, use of treatment escalation plans, and also the News 2 scoring system, which Hang's going to talk about. So I'll hand over to Hang now.
Yeah. So my name is Phan, and I today I'm going to talk to you a little bit more details about the infrastructure as well as the work that we did in response to COVID, and how it can help us to support multiple research projects and also operational support as well. So Matt has explained quite a lot of things that has been going on inside the hospital. And for us as a research support unit, what we have managed to do over the past 2 years to build the capacity to help us to pick up and respond really quickly in this pandemic situation. So we have managed to get our hands into the electronic health record of the hospital. We have access to their the patient's clinical details. And then we have also managed to build a pipeline to process the data in terms of extracting, anonymization, quality checking, and manage to transform them in the pipeline, then take these data and deposit them into a cloud-based server, which is called BC Insight in our case, where we integrate all these data in a single place, which then can be used for analytical purpose to provide insight, as well as to serve for research purposes. And the platform that we're using is is a product of the BC Platform company. It is a platform that is safe and secure. We have user-based access where we can track what people are looking at, who have access to which data set via the detailed data sharing protocol. And it also has a very comprehensive data dictionary, which allows you to understand the data without ambiguity. It has lots of tools for you to help you summarize and report on the data, as well as some very basic visualization that can allow you to explore some more data in details. And the most important thing is that it has audit trail that can let you know what has happened to the data in the past, what changes has been made. This will be quite important when it comes to creating audit report and stuff like that. This is the timeline, which is quite similar to, I think in a way it's parallel to what Matt has been presenting, slightly a bit different, where the focus is on research projects. But on the 2nd of March, the first case was reported in our trust. And it's only 3 weeks after that that the UK lockdown has started, when the number of cases increased. And just 2 days later, James has gathered everyone in our group and say, hey, we need to do something. And that's where our COVID response group has started. And with the understanding that we have collated so far, we have managed to get the first data load into PC Insight 2 days later. And from then we managed to make dashboard plan for daily monitoring, where James and Matt goes to the head of the trust every morning to present what's happening in the past day and plan now for things that will go on in the near future. So to assist for that, the Power BI dashboard was built with the help of another member in our team to facilitate the presentation of the cases that are happening in the trust. And then we also incorporate the population data to see what's happening in the community, to align that with the planning inside the hospital. And from then, things in the hospital started to pick up. I think there was a question about how we manage the different groups, and probably that is where we're starting to pull our line, and we focus more on doing research projects rather than the operational side. And that's where we started to get involved with projects such as point-of-care testing for COVID-19, AeHIN cardiovascular program, which is a program to look at the COVID data for cardiovascular diseases, and that is a national collaboration program. Locally, we also have REACT study, which looks at the ICU admission, and on another side, later on in May, we started to get involved with the News 2 national group. So here, News 2 is the early warning score being used in the UK, which I'm going to explain a little bit later after this slide. And more recently, we get involved in the service evaluation within the trust on the asthma project, and also another research project on COVID hyperinflammation. So far, we have gained some experience during this outbreak, is that we have managed to quickly identify and extract a lot of data items, but there has been also a lot of caveats to it because of the constant changes of test code that happened earlier in the outbreak, where we didn't really know what was the best one to take. And there was doubt about the quality of the test and things like that. And it's only after March that things started to ease down, and we have a stable system. We also identify problems with our data integration platform, which we didn't know previously. There was a very urgency in terms of the requirement to turn over the data for outbreak management. And when it comes to the different research projects, then we also had to deal with a lot of the differences, although very minute, between different projects regarding to cohort identification or data items that has been required. However, with the collaboration with the Trust IT as well as the company that is supporting the data platform, we have managed to overcome a lot of difficulties, and we're still in good terms. And all of this work has been embedded within the BRC Data Science where I belong and within the Zero unit here. So just to give you an idea of how the outbreak looked like in our trust, as of the 7th of July, we have had a total of 823 positive patients so far. And that is out of 34,000 tests that has been conducted. And the total number of patients that we have tested is 20,000. So you can see that the number of cases has decreased quite a lot, while the testing capacity has been increasing. And in terms of the gender distribution, there has been more male patient becoming positive than female. And in terms of the age distribution, it's similar to what's happened elsewhere, where you have more patients in the older age group. And on the right-hand side, there is the graph about Charlson Comorbidity Index. So here, Charlson Comorbidity Index is a value that summarizes what's happening to the patient. So the more condition you have, the older you are, then the score is higher. So by splitting them into different groups of having COVID or not and being alive or dead, you can see that most of the time the group with the COVID condition has lower comorbidity score than the group with higher that are alive. So it is a very strong indicator that COVID status itself is a contributing factor to the death status of the patient. So then I would like to talk in a bit more details about the NEWS2 project, which I mentioned earlier. So we have been participating in updating the NEWS2 model led by King's College London. And the aim of this project is to improve the NEWS2 model. So here NEWS2 is the early warning score combining 6 different observational values, including heart rate, respiratory rate, blood pressure, oxygen saturation, and something, just one more thing I need to remind myself, but always forgetting. So the aim of this project is to improve the outcome prediction by incorporating some additional routinely collected data items such as CRP or hemoglobin. So that is what's going to be the outcome of the model. So in methodology, we have been using logistic regression and decision tree. And the result is that the final model include NEWS2 and 5 other features, including age. And we have been participating in this project as a validation site. And that is combining data from King's College, 2 other sites in the UK, and the Wuhan data. So the data has been submitted, and we are waiting for the responses. Meanwhile, we're also trying to improve the model by using the more contemporary machine learning approaches like random forest, and we're also in the process of testing out the performance of this over logistic regression, and training it on bigger data set might help improving the outcome of the model. So far we have been performing a lot of supporting activities, and we're continuing to deliver more supporting activities to different research projects, as well as operational projects if required. And those involve the data extraction, integration, hosting management, and analysis and machine learning. And I would like to thank all these people who has been really great in the process of putting things together, talking to people from technical group and making dashboard and stuff like that, and also other research groups as well. And now I would like to move over and invite Dr. Pradeep to talk on his project.
Thanks, Hang, and thanks, AeHIN, for giving us this opportunity to present what's happening in Southampton with regard to COVID-19. I would like to showcase a platform, which is the COVID Digital Solutions platform, which was developed by the Southampton University, and now being be able to for you to have a look at. So this all started when 7 digital health fellows took up their job role in Center for Digital Health at the University of Southampton. This Commonwealth Center has hosted these digital fellows, and they were looking at this Commonwealth Systems Framework for Healthy Policy, which basically focuses on advancing global health security and sustainable well-being for all. It's a holistic view, and it's a system strengthening approach in collaboration with the public health approach to address sustainability and health security issues. So this framework gave us the opportunity to look into different aspects of healthcare service as core items and as system enablers. So these core items were health prevention, protection, promotion, and people. And the enablers were the governance, the advocacy, and the knowledge and the capacity building aspects of it. Under this initiative, we took up the task of identifying digital health solutions which contribute to this cause, this framework. So we were doing a kind of work trying to create a platform for planet, place, and people, which is what is called, to identify these digital health solutions and host them. Once this was going on, of course, the COVID pandemic came about, and that created havoc around the world. And as you all know, we were faced with many global and local challenges. These challenges were in the form of, resource allocation, remote care, and things like that. And while everything was going on, a lot of digital solutions which came up made quite a good impact in overcoming these challenges. So some of them were in telecare, telehealth, contact tracing, even online triage, and also in the form of giving information and data at where it is required, and in a very timely and accurate manner. So there came the problem of identifying good solutions, with digital health solutions, which can be taken up and reused by by countries and institutions with limited resources, like lower and middle income countries. Then we all wanted to identify what at a global scale, what can be given as development and sustenance of support for these solutions, and also to build partnerships around this matter. So the vision of this platform was to host and support proliferation and promote the utilization of a digital health solution for management in public health emergencies. And we had a few goals. One is to come up with such a platform and take up some digital health solutions and make them visible at a global scale. And also make this platform a place to share experiences. And also learn from failures or successes that has occurred by using these digital health solutions. And also to create the partnerships that are needed at national, regional, and global scale, and to promote open source digital health solutions as well as open data and related research. So the platform was had a soft launch on 6th May at the Commonwealth Civil Society Policy Forum, and also had a launch later on at the Commonwealth Health Ministers virtual meeting. The URL for this is cds.cwcdh.org, where you can go and have a look at this. The key features of this platform are that you can upload, then we provide the hosting facility, and we also provide grounds for sharing case studies, which are the experiences of people who have used these digital solutions. So first we look at how we enable the upload of or intake of digital solutions. We have a interface where people can self-upload these digital solutions, and these solutions will be looked at the back end, curated, moderated, and enlisted in the platform. When it comes to hosting, we host these solutions in a way that people can easily find out what is there. So they are being categorized according to the different areas in a general pandemic situation. You have surveillance solutions, screening, diagnosis, then for treatment, and also for planning and strategy, and as well as you have different solutions which cater as dashboards. Then we display featured products, top products, and case studies, and people can come here and identify and do a search according to categories, implementation levels, and keywords, so that these solutions can be, the ultimate goal is for reuse, so that people can find and reuse. So some of the details that we carry are basically aimed at two aims. They have two aims. One is to give an introduction to a solution, then to make the communication, the vital communication that is needed, so that you people can link to the real developers of these systems and make sure that these can be reused. So the details go as a small description, then you give us a solution category, then you have the planet fit for people categories, then solution types, whether they are mobile or standalone, and solution functions are detailed, and the user groups, what type of users are using these systems, the implementation scope, the country, if it is an international solution, then operational languages, internationalization, license type, and also more importantly, how you can link with the people, like the demonstration sites, the application site, the download links if they have provided, and the details of getting the communication or the link through. Then we have a way of displaying case studies to share experiences. This is to identify and promote success stories, and as well as learn from the failures. So the current usage, this has been active for 1 month. In the current usage, you can see that the average session time was about 7.5, about 7 seconds, which is quite okay for some of these sites, because they just come and have a look at it for quite a significant value. And also the upload page has been looked at 5%, nearly 5% of the time. So people are interested in making uploads. Geographical distribution is you can see North America, then Australia, India, Pakistan, and Sri Lanka, and also some countries in Africa, then European countries, and basically UK as well. So this is the team and the partners. We are the Commonwealth Center for Digital Health, which is affiliated to Commonwealth Medical Association. And we are hosted by the Clinical Informatics Research Unit at the University of Southampton, and we are also affiliated with the University of Colombo and Health Informatics Society of Sri Lanka. This thing was, being given approval, and there was an advisory group with Professor Vajili Sanayaka, Dr. Joannos, Professor James Batchelor, and Dr. Chris Williams being part of that, and also the team that was involved is shown below. So what's next? We want to try to promote and encourage digital solutions uptake to this system, and also improve the visibility and usage by linking to the platform for planet, place, and people, so that there will be more solutions and the visibility is there. Okay, that's it. And I would like to thank you. I would like to hand over to Dr. Buddhika Ariyaratne for his presentation to continue.
Thank you, Pradeep, and thank you, AeHIN. Hello and welcome. I will present a study conducted by the Clinical Informatics Research Unit of University of Southampton. It's on data management during a pandemic, proposing a minimal data set and open database using COVID-19 experience. COVID-19 was declared as a public health emergency of international concern by the World Health Organization on the 30th January 2020. It was referred as a pandemic by the public. It has compelled global health authorities to take urgent measures of control. High quality real-time data collection, aggregation, storage, analysis and exchange are of utmost importance for planning, management and implementation of control measures at local, national and global levels. Inefficient data management aggravates not only the health burden but also worsens the socio-economic consequences. Absence of a common minimum dataset and an open database have led to difficulties in global sharing of timely information. Currently, almost all countries operate their own data management platform for internal use. Most countries have established mechanisms to make the aggregate data public. Meanwhile, countries like South Korea, Singapore, Thailand have published anonymized individual patient data, yet they do not follow a universal format, hindering efficient utilization. The World Health Organization has designed a case record form in a paper format with comprehensive clinical data for COVID-19. The objectives of this study is to explore the potential for a globally accessible data sharing platform managed by a World Health Authority using a minimum dataset and an open database for all aspects of pandemic management at every stage. The methodology consisted of two components. First component was a rapid literature review to find existing information about minimum datasets and the open databases related to pandemics. The next component was focus group discussions, which evaluated the gathered knowledge and developed the minimum dataset and specifications for the open database. The focus group discussions among clinicians, public health specialists, health administrators, researchers, and medical statisticians focus on identification of relevant variables. The focus group discussions with health informaticians and ICT professionals revolved around the profiling of identified data elements, defining data types, data structures, data standards. Video conferencing platforms were utilized for all discussions. The review of the literature resulted in 71 publications for the minimum dataset and 3 publications for the open database. The articles have described the development, the usage, and the importance of minimum datasets, few of them in the context of epidemics or pandemics. They discuss the elements related to patient-specific demographic data, episode-specific clinical data, socio-demographic characteristics, health conditions, preferences, and treatment. Some have described the development, planning, data acquisition, modeling, and maintenance aspect of an open database. Focus group discussions among clinicians identified variables related to demographic and socioeconomic data, comorbidities, investigations, therapeutic interventions, medicines, and other important data for planning, resource management, analysis, and research. The data values were discussed mainly in the context of COVID-19. Focus group discussions among health informaticians and ICT professionals listed, categorized, profiled the variables identified by the clinical group. The result was development of a minimum data set consisted of 39 data elements which accommodate the variables identified. The identified data elements were categorized into 5 categories, namely patient-specific demographics 14 elements, patient-specific clinical 7 elements, exposure episode-specific exposure data 4 elements, episode-specific management data 10 elements, and user or system or data-specific data 4 elements. The identified elements are mapped to aspects of pandemic or epidemic management. This resulted in 8 elements for disease surveillance, 24 elements for screening and quarantine, 24 elements for clinical management, 39 for contact tracing and follow-up, and 9 for research. Every element of the minimum dataset was labeled with a name, description, and a data structure. Custom data structures were proposed where needed and described with the name, data type, and a cardinality. Many international standards were identified in coding of data values like HL7, SNOMED, CT, LOINC, and ICPC. All the details of these results are listed and the link is attached to this slide. The key specifications formulated for the open database include a relational database, a web interface, an application programming interface or API, a mobile application, and RSS feed mechanism. Details of authentication and authorization mechanisms and public accessibility principles were identified as essential. The study revolved around addressing the need for developing a minimum dataset and open database which supports timely, accurate, and complete global data sharing in pandemics. There had been many instances of developing a minimum dataset for management of other health challenges, yet there has been only a few instances where minimum dataset used for infection management earlier. The emphasis on the importance of credible information for multiple aspects of COVID-19 pandemic management. Multiple information requirements for disease surveillance, screening of at-risk groups, contact tracing, clinical aspects, including follow-up, generating information related to health system operations, planning, management are addressed in this research. There are clear challenges to the implementation and uptake of the minimum dataset. They are related to contextual aspects, country capabilities, and ability to mobilize resources efficiently. This was a rapid review of literature in response to a public health emergency, and as such, limitations reflect the short time scale. There was a limited use of medical research engines and a limited cohort of individuals in focus groups. It is recommended to build upon this initial attempt, and this needs to be validated in the setting designed to be applied. And I would also, I like to, this article recommends the use of minimum dataset and subsets for the efficient use of data managing all stages of pandemic. The data structures, interoperability issues, and standards of terminology are recommended here. The management of an open database would best be done by a world authority like World Health Organization to facilitate simpler utilization of near real-time data organized across multiple settings. The proposed minimum dataset can be customized at country level for other stages of management like population screening, patient management and follow-up, and contact tracing. So I would like to thank all those who supported this project, and I would hand over to Professor James Batchelor to conduct the sessions related to questions and answers. Thank you.
Thank you, everybody, for your presentation, which I think very succinctly covered the number of different projects that we've been working on as a department, both for our own local, national and international efforts in ensuring that we are well armed with information around this particular pandemic. And I'd be grateful if there are any questions for the team who've presented.
Yes, thank you to our speakers and Professor James. There are some questions in the chat box. So the first one is, who was coordinating the informatics work of various groups? Wasn't it chaotic at the beginning with lots of overlaps between groups?
It's a good question. I think certainly from I think across the country, a large number of people suddenly had to become very mobilized. I think pandemics are an interesting scenario of a prolonged emergency. Normally we're used to dealing, particularly within medicine, a short acute period of an emergency, like a big train crash or something like that, and it may happen for a very short period of time. What's really evident in this particular pandemic is that this is a prolonged period of ultimately emergency planning, and that does and has required a lot of coordination. And from an informatics perspective, from a Siro perspective, we were very coordinated because the way and the nature that we operate as a team being very coordinated. And because we have a number of clinical staff who are clinical informaticians within the department who also have clinical roles such as Matt, that means that we were very able to very quickly coordinate the needs with the teams, the senior clinical teams within the hospital, to be able to respond to their actual immediate needs and information that they needed. And obviously there is a hospital informatics department and a sort of university clinical informatics department, and we are able to coordinate naturally with them through particularly our colleagues who work on the development of our electronic medical records, whom we work very closely all the time to be able to help us do that. So new people from outside of our direct team were engaged with us. So normally Hang's Axis team consists of about 3-4 people, but we brought in other people from the rest of the department to try and help. So our colleague Pat Oxford, but also Alan Hayes, who is responsible for the development of the PR historically within the Trust and Davy Cable. So I think we just naturally managed to coordinate our efforts reasonably well, and there are lots of other people doing work around the rest of the university, and the university tried to coordinate the response to COVID, not just in informatics terms, but across the piece in terms of the involvement of engineering, developing new respiratory protection systems that Matt showed very early on through our Institute for Health, IFLS, Institute for Life Sciences. So as a university, I think we coordinated our efforts. I think there's a lot to be learned from this about how we could possibly do it better, but overall I think we were well coordinated.
Yeah, I'd just add to that I mean every hospital has got an assigned COVID lead, and James and I were working very closely with the COVID lead, and he did an excellent job of coordinating things within the hospital, and I think having a few key people who are responsible for the coordination and leadership of these things is critical. And I think we had that.
Yes, thank you, Professor James and Dr. Matt. So the next question is, how did the NHS or UK groups manage privacy or confidentiality of COVID test results?
There's a good question. So thankfully we have something which Matt alluded to earlier, which is our Public Health England organisation, which normally deals with recording and collecting information about what we would classify as notifiable diseases in the UK. And admittedly, they are normally scoped to quite specific diseases and don't tend to arrive in a huge wave as this particular pandemic does. And there are very strict controls in the way we report that information to PHE. So we report the clinical information as identifiable information to PHE, and then PHE basically then normally undertake contract tracing or following up on clinical matters relating to those diseases. Here in the UK, what they've done is PHE has taken the leading role nationally in anonymizing that data and being able to, from a government perspective, produce our national statistics relating to COVID infections and recovery and deaths. So that's been coordinated nationally by PHE. Locally, our systems in the hospital are obviously clinical systems, and for research, we then have very clear processes and procedures by which we anonymize and give patients a sort of a unique identifier, and the key for that is held within the hospital and it's not held by the university. So there is a link to be able to do that, and that link traditionally is managed through the Edge platform, which is another piece of software my department produces, which normally on a day-to-day manages that linked anonymization process to blind, as it were, university or researchers from actually who these patients are. So a combination of existing processes that are in place, as well as utilizing certain infrastructure that lives in highly secure computational data management storage environments, both in cloud and on premise, and our national body of PHE taking the responsibility for our national reporting.
Thank you, Professor James. Our next question is, what is the role of national agencies like NHS or Public Health England with coordinating data flow among the trusts?
Matt, I'm going to leave this one to you because you did.
Yeah, so it's obviously a link to what James was saying. So each trust acts as a data controller and holds the data of its own patients, but Public Health England collect that data. So they collect the lab data and sort that all out. They also collect aggregated statistics, and they collect patient level data as well, and they're responsible for anonymizing that. The other national bodies, so NHS Digital, NHSX, all these other groups that are involved in the national coordination of data, have their own mechanisms for processing that data and keeping it safe. The data, there are ways for other people to access that data if they have the right reason to, but only in an anonymized fashion. Hospitals themselves don't normally transfer data across. So for instance, unless there's a real need or a set up program, for instance, for the News 2 model, me and Hang did was basically validate a model. So the model came into our hospital and then we validated it on our own data, but no data left the hospital. So the only thing that crossed was the model. But the main question thing is about the NHS and public bodies. So there are these national bodies which do this, and they perform that function, and we contribute to that process, but they manage it.
There's something I would like to, well, maybe not related to this question, but there was a question earlier regarding the encounter of challenges of competing application between different groups. So I would like to raise the example of the HIC program. So HIC stands for Health Informatics Collaboration. And this program, which we participated in, was combining or asking multiple BRC centers to submit data of the patient from their hospital into a common database held by, say in this case, the HIC cardiovascular group being led by Imperial College in London. And the program collects a whole lot of data without specific questions to be answered for research. So what happened after these data has been collected is that every center who is participating in the program will propose a research question to the governance body, and they will approve the research question. So in that way, they can coordinate the people who wants to do, so say if there are two centers who wants to answer the same question, then they will match up these people so that they can collaborate each other on the same research question. So there's no competing of interest here, but we just work together to answer to the same question. So that's how it's being dealt with in the example of the HIC program. And also in the same manner, I think projects that come to us asking for contribution of data or supporting with data, we would try and see whether they have like overlapping interests or not. Normally what we have seen is that there are some overlapping, but when it comes to the specific questions, it can be quite different. So it's not really overlapping at all. However, if we do see that there are any overlapping of interest, then what we normally do is to let these people to talk together and collaborate rather than competing with each other, because that will just creating a very unhealthy environment.
Yeah, good point, Hang. Cool.
Thank you, Dr. Matt and Dr. Hang. We have another question. So I would like to know which kind of standards were used or can be used to exchange data at the global level.
So I'll try and answer this, and then Boudica may have and Ari may have a particular viewpoint on this. I think the question about a minimum data set is very critical. I think this is the one thing that we've learned from this and is well cited in publications, is the data is very important for us to understand this, and being able to aggregate data sets from multiple different people, be they clinical, non-clinical, operational, whatever it may be, I think is very, very important. And that's one of the reasons why we try to think about what this minimum data set could be, so that we could at least try and apply some standards, both in terms of the data we're actually capturing, what we mean by those data variables, and what we would expect to see in terms of responses to those particular questions and variables. But then I think it's an ability for us to agree a set of standards in terms of transmitting that data to somewhere potentially centrally as a collaborative to pool the information, so that internationally we can look at both clinically the presentation of this disease, but also look at what is its current sort of state and depth of infection globally as well. So I think we do need to think about how we do that. And I think Alvin asked a question about running a separate workshop on this minimum data set. And I think it's critical that we try and do that. The paper approach is slow and clunky. The minimum reporting about number of episodes and recoveries is useful, but I think we need to go to a greater depth. If we're talking about, is there a specific standard we've used, certainly I would say in the UK, no, I don't think we have used a specific standard. We've been sort of dreaming one up as we kind of go along. And actually, in terms of integrating the data sets that we have managed to collect nationally, such as the chest data set, it's been very ad hoc, and to be blunt, it's predominantly been sent as comma-separated value files, which have been then agreed, you know, what variables go in what columns as a standard to be able to try and facilitate pooling that data together. I don't think it's been anything actually very, what's the word, complicated or technical in approach, like using FHIR or anything like that to send messages to a central repository. It's been more of a needs must, and what's the quickest and easiest way to be able to do that, I think, unfortunately, is the answer to the question. But I do think working towards a minimum data set can help us to harmonize the data we're collecting. And I would strongly hope that this this minimum data set and paper that the team have been working on here is something we could share and agree on as a group with AeHIN and others to be able to try and facilitate that common approach.
Yeah, I think Professor James answered the question. But if you're asking specifically standards for each data element, we have described them in detail, and it's too technical to discuss here. For example, for country, we have used international country codes, ISO 30166, and for medications, ATC, RX norm, DMD, like that we have proposed some. So it's too technical, and all the details are there in the link. Thank you.
All right, thank you, Professor James, Dr. Matt, Dr. Pradeep, Dr. Hang, and Dr. Ari. Thank you so much for making time for us and for sharing your experiences and initiatives in Southampton.
Thank you, James and team. I think let's move with the workshop on the minimum data set. I think there will be several institutions that will be interested in joining your effort. So let's work on that by email and then invite the participants in this call to that workshop. Thank you, guys. Thank you. Great work.
Thank you, Alvin, and
Thank
thank
you.
you, AeHIN, for your time. And I
Thank
wish
you.
everybody a good
Yeah,
evening.
thank you, Ian.
Thank
Bye.
you.
Bye-bye.
Bye, bye, bye.
Take care.